So the first thing that we, and very important ceremony that we have to do in this section is announce the winner of the People's Choice Awards, so frantic counting from the barrel since lunchtime, thousands of votes, an election that I can assure you, unlike the American election, was not rigged. And I invite the Minister, Jillian Skinner, to announce the winner.
Thank you. You know, he wouldn't let me have this ahead of time. He thought I might open it and cheat. Look, because I voted, and I'm sure it will be the one that I voted for. Of course it will. The People's Choice of Award goes to Caring for Our Carers, Western Sydney Local Health District. Fabulous. Wonderful, wonderful choice. Thank you, everyone. Thank you. Thanks.
So you've had the Festival of 60-second Contagious Ideas, and now it's time for the pitch. And what the pitch is that essentially a seeding grant has been offered by the Minister to offer ideas to the Minister for startup projects, and the prize is $10,000. And we have 3 finalists in that category who are going to come onto the stage and do their pitch. I'll just quiz them a little bit about what they're up to in their ideas. If they're not absolutely clear from their pitch, even if they are, I'll still do that. And then they will be judged in real time by our totally unbiased, unrigged judging panel, Sam Sangster, who no doubt will only vote for the ones that will save him on money on infrastructure, the Minister who will only vote for things that she likes, and Zoran Bolovic, who's going to, I don't know, connectivity. But anyway, those are the judges, and they will think very quickly on their feet after the 3 pitches, and we will then award the check to the winning team. And our first finalist is Connecting Family. Oh, this is one that Zoran's going to like. Connecting Families When Most Needed, Hunter New England Local Health District. Please welcome.
Good afternoon, Minister, judges and colleagues. Today I'd like to talk to you about connecting families when it's most needed.
Tom, is that you?
Yes, Mum. It's 3 in the morning. Why are you calling me?
It's Dad, darling. He's had a fall. I don't know what's going to happen. I don't know. They just said it's really bad and they're sending him to theatres.
He'll be fine. He'll be fine. It's all okay.
Darling, I don't know. I don't know what I'll do without him.
If you are the person that receives this call, panic will kick in. Over the next hours, you'll probably ring your mum a dozen times. You might be thinking, I need to get home. I need to be there with her. Whatever you think, if you're not in the same town, if you're more than a few hours away, the sudden sense of uncertainty you now have will turn your world upside down. At John Hunter Hospital every year, almost 700 people will die. Around Australia, that's almost 150,000 people. This is not all trauma and accidents or known palliative care patients. This is people like you and me, people getting older, medical complications, chronic illnesses. I know 2 things about this. I know that no family is ever truly ready for the death of a loved one, and not all family can always be there in time. We live in a society that's geographically large and culturally and ethnically diverse. Our families can be spread across the world, or across the country, and wherever you are, when this bad news comes, your distance is felt stronger than ever. This is what happened to Dave. What started out as a sore leg quickly became a life-threatening illness, and within 24 hours, it was established that Dave was going to die from complications of an ischemic leg. Dave's son Tom was in England. Throughout the night, he received text messages from family. It's not good. Things aren't going well. I'm coming home, he said. Dad's going to die tonight, they said. When someone is dying, we try to provide the best possible end-of-life care, addressing physical symptoms, family support, cultural and spiritual needs, and affording families and patients the opportunity to right their wrongs and to say goodbye. Using a secure telehealth link with 5 family members surrounding Dave at the bedside, we connected to Dave's son and granddaughter. A 3-way video link happened for over 1.5 hours in a quiet space together, where all members of the family were able to connect, share each other's pain, support each other and Dave, and say goodbye. As you would all know, delivering bad news to anyone is challenging, not just for families, but for healthcare staff as well. But what happens when distant families are told someone's dying and they don't believe you? And they say, do everything you can, you have to save them. How do we help in those situations? This happened recently. A lady in her mid-90s, very unwell and likely to die in the coming days. Her son was on the trip of a lifetime. He couldn't get home and he wasn't ready to believe that his mum was really dying. He was the enduring guardian and he told the doctors from Europe, do everything you can, you must keep my mum alive. Video conferencing enabled us to connect this family via a laptop with a webcam attached on the bedside table so close to his mum. Mother and son spoke for 2.5 hours over the next couple of days. The son was able to see how unwell his mum had become, and the reality sunk in. They talked, they laughed, they cried. The son commented after the second call, I know now that I've had this time that mum's going to die. And she did. Minister, I want every patient and family at the end of life to have the chance to use this technology. In order to do this, we need your help. We really don't need very much. We already have access to telehealth, Wi-Fi connections and the computers. But I need access to education resources to be able to teach staff how to set up these meetings. I need webcams, speakers, and so people can see and hear each other clearly using hospital laptops connected at the bedside to hospital Wi-Fi. I want every doctor and nurse in my hospital to learn that if they're caring for someone whose loved ones are far away and we think they're going to die, that we can have medical conversations with families happening. I want this ability to be transferred across the state quickly to enable other families the same. And I want you, Minister, to motivate staff so that telehealth is normalised and accessible in our health system. I'd like to finish by reading an excerpt from a letter from Tom, Dave's son. Jeanette organised a teleconference call between Dad's hospital room, my niece and I. Jeanette explained how the call would proceed, and the doctor explained to us exactly what had happened to Dad and how it had come to be the position he was in. We were told that Dad would not have very long to live, only 24 hours. This was hard to hear and fully understand, and it happened so quickly. My niece and I were so grateful that we could see and speak to our family, to be with them in the room. To speak to Mum and Dad is an experience that I will be truly grateful for and remember for the rest of my life. To be on the other side of the world at a time knowing it would take at least 24 hours to get to Australia filled me with dread, knowing that I would not be able to see my father again before he died. Due to the teleconference call, I could see him, talk to him, and tell him I loved him and I would miss him. The service we had from Jeanette and the team to be able to talk and see Dad, hard as it was, is the closest thing to us being in the room with him. For this, I am eternally grateful. Thank you.
Well done.
Thank you.
Would you like to introduce yourself to the room?
My name is Jeanette Lacey and I'm the end-of-life care nurse practitioner at John Hunter Hospital.
If you won, what's the first thing you'd do?
Start planning, of course. We need help to get all of the staff in our hospital aware of this technology. I've used it twice and I'm lucky enough to work closely with the telehealth people, but I didn't really know that we had that ability to connect families when it was really important. And these two experiences that I've had have shown me how powerful this can be and how important it is for families. Without this, business gets left unsolved, and I think it's really important.
So why wouldn't you just use Skype?
Because Skype doesn't provide us with the security where we can transmit medical information the same as using the hospital devices can.
So you want to actually
we want to use hospital Wi-Fi, we want to use hospital computers, we want to use hospital secure data connections. But we also know that both of these conversations, one was 2.5 hours and one was an hour and a half, and using that on your personal data phone may not be a possibility for many families.
And in your experience in your service,
yes,
how many times a year would you use it?
Oh, look, my service is relatively new, so I've used it twice in the last 6 months.
Right, so
and the position's only been there for 10 months. So
congratulations, well done.
Thank you very much.
And good luck.
Thanks.
The finalists, by the way, are in no particular order. They're equal finalists, but the second finalist to present is In Situ Simulation Training in Individual General Practices, and it's the Illawarra Shoalhaven Local Health District.
Really good to come along and learn about You can tell by the way I use my words. I'm a woman's man.
Oh, are you all right? Doctor, there's been a lady fallen over in the waiting room of your general practice. Should I ring 000? Oh, yes, I will. Beep, beep, beep. Hello, ambulance. Yes, I need an ambulance, please. Right away. I've got a lady down. I'm in Moss Street Medical Practice in Narrow, 1 Moss Street. Come quickly. 20 minutes? Oh. Clearly, ambulances aren't the panacea for cardiac arrests. Witnessed cardiac arrests in areas where we should be able to do better. So what we have is a situation where we could do better. There's statistics which actually show how much a widespread education program, as well as ready access to AEDs, can change the outcomes for people who witnessed arrests. They did a 10-year project in Seattle. It changed the survival rate from 26% to 62% over a period of 10 years. So it's a major change. You can see the graph here demonstrates that. My proposal is that we should at least turn our general practices into resuscitation centres. It's a way that you can deal with something. The first 10 minutes of any cardiac arrest is a critical one. So when people are distressed and come in with any sort of critical illness, then that 10 minutes in a general practice should be a very productive one, rather than one where you're waiting for someone else to arrive. How's she going?
She's all right.
Oh, thank God for that. Very good. Well done.
Back to the treatment room.
Yeah. Good. Very good. Thanks. So my proposal really involves training general practices, not in silos, which normally is the case. Doctors go and have their CPR training, nurses do the same. The admin staff don't get anything at all. My plan is really to create a situation where we actually have a team approach. So my topic of my talk was in situ simulation in general practice, and that is to take simulation training for acute deteriorating patients to general practices and develop teams who are comprised of the staff who are using their own equipment and are familiar with the surroundings that they're in. Every other team would do that. Hospitals do it, ambulances do it, but general practice, which is primary health, don't do it. I had this idea in my head, and I do some training for general practitioners, usually again to get their points in the silo, but I have an interest in simulation, so I often throw in some scenarios which are typical general practice scenarios. So they went through this skills training, but then went on to do simulation, and they realised just how much they could get out of doing that sort of activity, where they needed a team to actually achieve that. Some of the comments that I got back really spurred me on to think that there was something in my idea. Most of them would say that it was the best thing I'd done in years. When can we do it again? Some of them actually said, I'd like to do this in my practice. That was absolutely fantastic. It's the response that I was actually hoping to get. Because any project like this isn't sustainable unless general practitioners see some value in it. Okay? And I think that was sort of reflected back to me that there was some value in doing this. I see this as perhaps the start of a new path to accreditation. I think that if the general practitioners are trained in this way, then it'll become clear that there'll be a certain quality of the general practice. The communication skills, the acute skills will be respected by their colleagues, and so that the colleges, I think, will lean towards perhaps accepting the course that I'm putting forward as a way to go, which in fact a little bit better than the silo-driven one that we have at the moment. This goes on from there because I can see that there are standards relating to general practice accreditation, and if that becomes part of the accreditation, that you actually have a team-based approach to cardiac arrest in your practice, then I think that's a real selling point for that practice. The other benefit to it is one financially, in fact, because all this would be done in your practice, so there's no site costs. It's a group of trainers who train everyone. People don't have to disappear to various places to achieve this, and that will make certainly it's far more cost effective because we would go to them rather than they have to come to us or come to Sydney. So it's quite good value for money. That I think would make it sort of contagious once people realise that you can have it done at home rather than having to travel all the way up to Sydney. So that in itself is a simple selling point. But the other selling point is the way that people will view this from the outside. I think that people, anybody who's in a local health district who can see that one health district is doing something better will actually try and mirror that same practice, I guess, in a sense. And I think there's one that where we can actually lead. And so that it is sustainable in other areas other than my own. We'd be looking to critical care specialists and GP anaesthetists to perform, having done a train-the-trainer task to understand what we're after, to actually do the training at that sort of level in those practices. It's transferable really to any health facility, be it either one which is Aboriginal health or whatever. Now the way to sell it is also the fact that is with a branding. This is something which I put forward. If people achieve a certain standard which we're happy with, then they would have this logo which they could display on their practice. And basically the catchword is GP Resus Ready. Okay, and that in itself is would be a status symbol for them for accreditation, but it would also indicate that that particular centre has quality care that's on offer for any emergency situations. So I think that would be a well sought after point. I'm not sure I haven't got time.
You're
well within time. Okay. This is really all about breaking down barriers. I'm very inclined, I'm a specialist anaesthetist, so I don't work in general practice much, but I have worked as a general practitioner in the past. I understand the loneliness of trying to deal with something that you haven't dealt with very often before. I understand the extremes of distance that exist in a lot of rural areas. I'm in Shoalhaven, so we have a lot of outlying GP practices, single practices, who are well and truly 20 minutes or half an hour, three-quarters of an hour away from any sort of assistance. So this is a way of giving them confidence and giving them the ability to actually stand up and be proud of what they do.
Thank you very much.
Thank you very much.
George, just introduce yourself.
Pardon?
Introduce yourself.
I'm Taff Hughes. I'm a specialist anaesthetist at Shoalhaven Hospital in Nowra.
Have you any idea how often this happens in the GP waiting room?
No, because no one keeps figures. I think the way that this works, there is an attempt, perhaps in some, but not necessarily in others, depending on the equipment that they have. I don't think necessarily everyone has an AED. I'm not sure, depending on how far out the practices are, how many people really are up to date. I don't know, because of the influx of other practitioners into our area. We've got a lot of overseas trained people, quite where their standards are. So the numbers aren't there, but there probably are numbers of deaths that are there that may not necessarily be.
And can you charge for a long consultation for a long research? That's right.
I think the glow that someone gets when they actually get someone back, as you saw with Helen here today, is one of the selling points for it. It's a very proud moment when you actually see someone get up or actually speak back to you, when you know that life is literally extinct if you didn't do anything.
Thank you very much. Congratulations.
Good.
And
Thank you very
good
much.
luck. I always think that these things, the worst that can happen is I don't get invited back. The third and final finalist in this section is Blurred Minds, Idle Hands. It's Time for Change from Sydney Local Health District.
straight this way.
The wife is requesting St George. That's it.
Of all patients aged over 65 admitted to RPA have a form of cognitive impairment. On our ward, that can increase up to 70% at a given time. We already know that a patient admitted with dementia costs the health system 2.7 times more than someone without dementia, and they have an increased length of stay, which is twice as long. The scenes in the clip that you have just watched of a busy acute care unit will be familiar to you in this room. However, if you pause and imagine looking at it through the eyes of a confused older person with dementia, you can understand how overpowering these sights and sounds might be. We ourselves did not fully understand until we conducted a dementia environmental audit as recommended by the ACI. To our horror, and we failed miserably, we knew that we were working in an environment that was not purpose-built for the needs of our aged care patients, but we did not realise to the extent which our current environment was having a negative impact on our patients, family and staff. The audit design looked at 10 key principles for the care of patients with dementia. These principles have been published by the ACI, and the process of working through them is underway with the support of Professor Richard Fleming, an expert in the field from the University of Wollongong.
Unfortunately, we don't have time to look at all the principles of change, but some of the key things we want to do is we want to unobtrusively reduce risks. We want to create a safe and secure environment that is easy to navigate. We know that patients with dementia are 8 times more likely to fall over whilst in hospital. We want to allow people to see and be seen by creating an environment where key places such as the toilet and bed space can be easily located. An easily understood environment is a simple environment which decreases stress and agitation. We want to reduce unhelpful stimuli, which has been shown to decrease the incidence of aggression and anxiety, and optimise helpful stimuli by making doors and entries to patients' areas easily identifiable through the use of colour and font size. This is what we have, dark and hard to find, and this is what we want, bright and easy. We want to create familiar spaces by personalising the environment to the individual and ensuring fittings are familiar and easy to use. This can be very simple things like having a traditional style toilet roll holder in the bathroom instead of the dispenser you see in the video. We want to support movement and engagement by allowing for purposeful, not aimless wandering and disguising exits to decrease feelings of entrapment. These principles can be seen in practice in areas such as nursing homes, children's hospitals and mental health units, but why not in the acute care setting? By making these changes, we can create an environment that improves the hospital experience for every patient, every staff member and every person who walks into our ward.
We strongly believe that the principles outlined can be adhered to in any acute care unit. There is no requirement for a new build. It can be as simple as moving some furniture or adding some clocks, for example. The audit tool that we used provided us with the framework to move forward, and this startup money will assist us in implementing these important changes with the assistance and expertise of Professor Fleming. The RPA executive has demonstrated a strong and ongoing commitment to the care of patients with cognitive impairment, and we as a team are grateful for their support. In closing, we would like to reiterate our passion and commitment to providing an evidence-based, best practice therapeutic environment based on the principles outlined, which supports us in the clinical care provided to patients, as well as a calming environment for families and staff. Thank you.
Thanks. So the person holding the purse strings for infrastructure build is in the judges. So I think if you're going to have a chance of winning, you're going to have to convince him that this isn't going to cost him a fortune.
We know that these changes can be really simple. They can actually be implemented without actually making any structural changes. It can involve some paint, it can involve just changing signage, making sure that the signage is appropriate for people with cognitive impairment who have issues often with glaucoma. So we need font sizes to be cognizant of that. So this example here, a patient with visual impairment with dementia is really going to struggle with finding their bed number. But if we say, you're in bed 3 or you're in the blue room, they're more likely to follow that.
And we want to colour code them. So instead of saying you're in beds 1 to 5, we're going to say you're in the purple room or you're in the pink room. It's much easier to navigate.
And this has been proven to be effective within residential aged care facilities, and the principles that they've used in those facilities can easily be transferable, not only to an aged care unit, but within any acute care unit.
So my question is, some of your, there's various facilities in Sydney Local Health District, but some of them are quite new. Have they been designed in a way which allows you to retrofit? Because sometimes there's not a wall like that to put number 3 on, for example. That's not malice on anybody's part, it's just they look better without it.
I think the advantage we have is that we've enrolled the expertise of Professor Fleming, who is an expert in fit outs for people with dementia, particularly in residential aged care. It's a new area for acute care, so we've engaged him and he's come to our ward and had a look, and we're willing to, or we want to be able to work with him to move the process forward. So we would be guided by his expertise.
And I believe with these designs, as we said before, it can be as little as making a toilet roll familiar to any patient rather than trying to, we've all been there, trying to get those little square papers out, to something big as redesigning a whole ward. So it could be, it's about making it clear, less stressful, the way you actually have the nurses station, instead of it all together, maybe split it into 2 halves. It's from as tiny to as large as you would like in retrofit.
And I should have asked you right at the beginning to introduce yourselves.
Yes. So my name's Wendy and I run the aged care ward at RPA.
I'm Vanessa, I'm the clinical nurse educator.
And I'm Annie, I'm the clinical nurse consultant for dementia and delirium for the Sydney Local Health District.
So thank you very much and good luck.
Thank you.
Thank you. Thank you.
So you brought your cheer team with you. So there you are, 3 finalists, while the judges confer to make up their decisions. You have the Connecting Families When Most Needed, a very moving presentation about connecting people who may be at distance, not necessarily overseas, but in other parts of this big wide nation of ours, to actually have an extended moment, time to actually consider end-of-life care when you might not be there, and using that technology in a much more sensitive way. And you could imagine other applications for this in a more acute situation, and really a very humane response. The in situ simulation training in general practice, well, you'd have to imagine that compared to the street, where there are lots of there should be lots of ADs, there aren't really, but compared to the street, general practice would be a selected population where you'd think that cardiac arrest was more common, and you'd like to think there are people there who could do this, but perhaps they need top-ups and a potentially valuable advance which would save lives and actually deliver people to the system who would then live productive lives. It's misleading to assume that CPR is a waste of time for a lot of people. It is not. Done well, it actually has good results. And finally, bird minds, idle hands. It's time for change. Very sensible approach to redesign, which they assure our head of infrastructure is not going to be very expensive, where you take a walk in a person's shoes and work out where the problems are to make it much clearer in terms of communication, and not just for people with cognitive impairment, dementia, but visual impairment and other problems. So congratulations to all those finalists, and I've blathered on long enough. Have the judges reached a conclusion? Yep, we have. Well, I invite the Minister to the stage.
I'd like Sam to talk about Bob Leese, because these awards are named after Bob, held in honour of Bob, and Sam had a very close relationship with him, and I think it's really important for just a couple of minutes, Sam, talk about Bob and why these awards and what are the criteria we're looking for in making this judgment about these pictures. Thanks.
Thank you, Minister. It's quite humbling to be able to have an award named after you, and Bob would be actually quite mortified that we were doing that to him in some respects, because it was all about the outcomes and the people that he served. It's actually really appropriate we're in this building. Bob built this building, and he built the rest of this venue here at the Olympics. There are very few pieces of infrastructure across this town that Bob actually didn't build or didn't have a significant hand in it, whether it's the tunnel that runs under the Sydney Harbour, whether it's this precinct, countless other pieces of infrastructure across the state. He built roads out at Wilcannia. He built the most amazing array of things, and let me tell you, was one of the best people I've ever had the personal experience to work for, and was really why I wanted to come and work with Bob. Why is it important that we recognise that? Bob had an absolute passion for innovation, drove all of us incredibly hard to deliver outstanding activities, outstanding quality, and really a true focus on how we left a better place than that we found before. And so it's incredibly humbling that actually an award minister agreed to create these awards this year and name this award in Bob's honour. We have the great delight of being able to award some money today, so I'll let the minister do that.
Thank you very much indeed, Sam. And you know, this pitch was about transforming health through digital technology or built environments, and we found it extremely difficult to judge these. Can I just say, in terms of the Hunter New England connecting families and the palliative care use of technology, this is something that I've been very familiar with, particularly in the pop-up model for children, paediatric palliative care. So I can absolutely imagine how transformative that will be. And that really is the digital technology, patient-centred element of these awards. On the other hand, the built environment is very much the blurred minds, idle hands proposition put forward by Sydney Local Health District for their dementia patients. So we had a real dilemma separating those two, so we've given them both first prize. So they'll both get $10,000. We've awarded the third one, the in situ simulation in GP practices. We've awarded you $2,000 because this is primarily a GP practice. It's a Commonwealth funded arrangement. We'll go to the Commonwealth and say, we've put up $2,000, how about you do the rest? So we'll provide $2,000 for that and $10,000 each for the other two. And never expect the expected in these pictures. Thank you.